Thanks for the invitation to contribute to this conference, and I will discuss the evolving role of PET in assessing cardiovascular disorders in various settings, in particular in head and neck and lung malignancies. FDG PET was introduced by investigators at Penn to look at central nervous system disorders, and then later we realized that cancer cells also have a lot of glycolysis, which FDG can detect. Infection and inflammation have become a major domain for FDG. Atherosclerosis, which is an inflammatory process, can be assessed by FDG. We can also see clots and in patients with various underlying disorders and myocardial variability and muscle dysfunction. So this has been a major addition to imaging domain and has truly revolutionized the practice of medicine as we know today. Of all the traces, and there are many of them over the years that have been introduced to the field, two stands out. One is, of course, FDG, and the other one is sodium fluoride. Sodium fluoride mimics molecular calcification in various settings, including atherosclerosis. So patients who have got plaques have a lot of macrophages and home cells that are inflammatory in nature, and we can detect it with FDG, but also we can detect calcification in the earlier stages of the disease. And that seems to be a very promising area of research with PET imaging. Because disease starts at the molecular level, and there it goes on for a while, changes function, such as blood flow through the arteries or any other functional activity, and eventually structural changes occur, which is the irreversible phase of any disorders, including atherosclerotic plaques. FDG, as I mentioned, is a very powerful technique to look at inflammation in the plaques. Sodium fluoride shows molecular calcification actively at the time of imaging, and eventually you will see calcium deposits that are visible on CT scan, which is the irreversible phase of the disease. So if we want to cure atherosclerosis, we got to look at the molecular phase of the disease, namely inflammation and molecular calcification. So by the time you have got these high density plaques, you have irreversible disease process that is going to lead to significant dysfunction and, of course, damage such as myocardial infarction or strokes. We can detect inflammation very effectively, as you see here in a patient with vasculitis in the entire subclavian artery. These are so vivid and clear cut, and we will see the effects of response to treatment by FDG in this setting. Because this is inflammatory plaques in the arch of the aorta that are lighting up so well, and this is, of course, PET-CT has become a major development in the discipline of PET, and so we can put PET and CT together or side by side and see the relation between molecular aspect of the disease as well as structural aspect of the disease. Sodium fluoride has a hope for looking at molecular classification and quantifying atherosclerotic plaques, and it just has been a major addition to cardiovascular imaging, and we have been again a major leader in demonstrating the efficacy of sodium fluoride in this setting. We conducted a very powerful study called Pomona study, which was an investigation initiated by us and conducted by us and colleagues in University of Southern Denmark in Odense, which really has shown further the power of both FDG and sodium fluoride in this setting. So this is showing you the aortic arch uptake of FTG and with low risk healthy subjects, and this is high risk patients. And clearly, we see the rise of uptake of FTG in the arch of the aorta with significance p-value less than 0.01 versus healthy subjects that don't show significant changes. So this is either clearly showing that inflammatory plaques in the higher subjects pick up a lot of FTG, and they can see it so clearly on the graphs that I'm showing you. Because we want to compare sodium fluoride uptake with FTG, and it turns out that sodium fluoride is more sensitive in detecting calcification. Even in healthy subjects, we see a significant rise with normal aging in the uptake of sodium fluoride, while FTG doesn't show significant changes. So this really shows the molecular classification as a very, very powerful domain for us to assess presence of plaques and therefore treat the patients early on. This should show you again sodium fluoride versus FTG in the aortic arch, and there's again very significant change on sodium fluoride versus FTG uptake. This showing that molecular classification is a good domain for us to assess the presence of plaques in various areas. Of course, we have looked at carotid arteries with sodium fluoride, and clearly high-risk patients have got significantly more uptake of sodium fluoride than healthy subjects, and this is very relevant to head and neck cancer because radiation therapy causes significant atherosclerosis in the carotid arteries after radiation therapy, especially photon therapy, and therefore FTG, sodium fluoride, will have a major role to play in detecting evidence for atherosclerosis and treating the patients accordingly. Also, this technique will show us how best we can minimize atherosclerotic formation in the carotid arteries by various interventions in radiation oncology, and therefore really minimize the side effects of radiation therapy in these very important areas. Of course, the same thing is applicable to radiation therapy to the heart for coronary artery disease. We have developed a methodology global assessment technique that we have called Alavi Carlson classification score. This is similar to CT classification score, Augustin classification score, that allows us to look at global evidence for atherosclerosis in the coronary arteries. So this is of course a subject with no calcification, a younger person, and this is showing you significant calcification. We just don't believe that either we have to look at specific coronary arteries to diagnose atherosclerosis. This is very significant, diverse disease, and therefore, in spite of lower resolution we have with PET, we can assess presence of atherosclerosis in the coronary arteries, and this is going to be of great value for treating patients with coronary artery disease. This is just showing you global classifications or in healthy subjects versus high-risk patients, and that clearly shows that we are looking at evidence for molecular classification very early on in these patients. Of course, inflammation due to radiation therapy has been of great interest to us, and we have measured the presence of inflammation in the entire lungs, and irradiated lung has got significant uptake of FTG and versus non-radiated areas. So definitely it shows the sensitivity of FTG in detected inflammation, even in patients who have no or minimal change on CT scan, show evidence for inflammation that we can detect by FTG. This is, of course, showing you, photon therapy, conventional X-ray therapy causing significant inflammation combined proton and proton therapy causing less inflammation, and for sure, proton therapy does not have as much uh, cause of inflammation, and therefore proton therapy seems to be safer way of treating various diseases and disorders. This, of course, shows cardiac inflammation in every location except for right upper lung, as, which doesn't cause cardiac inflammation. Any other locations in the lungs, it just is radiated, cause significant inflammation in the cardiac area, and that is another, of course, cause of atherosclerotic plaques in the coronary artery. So, if you are radiating, definitely left lower lung cancer, and even left upper lung or right lower lobe, you're going to see significant inflammation, which eventually leads to atherosclerosis, and of course, that's a major complication for radiation therapy of lung cancer. Radiation therapy, of course, causes inflammation in various vascular structures in the carotid arteries, definitely in the aorta, and here we've seen it in ascending aorta, significant rise of uptake of FDG, and as you see it here, it's a very significant p-value. So these, of course, may not be symptomatic, but definitely may be a cause of some abnormalities in other organs. Of course, one major area that we are interested in is importance of findings of atherosclerosis in the carotid arteries after radiation therapy for head and neck cancer. One of our colleagues at Penn has described this in great detail, and this is just showing you a brain MRI brain of a patient who was treated for head and neck cancer and has got all this influx. These are due to clots that were originated in the carotid arteries and then cause just influx all over the body. So we really are extremely interested in looking at both FDG as well as sodium fluoride in head and neck cancers, as well as patients who are treated for their breast cancer or left lower lung cancer, to detect evidence for atherosclerosis and try to minimize that in the future. So the conclusions are very clear. It's very timely that we design new studies to look at the role of this powerful modality in the cardiovascular disorders and preventing radiation-induced vascular injuries, in particular atherosclerosis and other organ complications. Preliminary data by FDG and sodium fluoride appear to be very promising, therefore need to be validated by well-designed animal and human studies. Again, thanks for the invitation.